Welcome to Health Yeah, where experts from Stony Brook Medicine come together to discuss topics ranging from the complex inner workings of an infectious disease to tips and tricks for staying safe and healthy all year long.
Hello, and welcome to Health Yeah. My name is Dr. Tara Huston, and today we're going to talk about all things breast health, from risk factors and screenings to mastectomy, post-reconstruction, and more. Whether you're preparing for your first exam or navigating life after mastectomy, this episode is packed with expert insights and tips to support you in your breast health journey. Let's get started. I have with me today Drs. Anastasia Bakoulis and Cindy Lee. I'm going to ask each of you to take a moment to introduce yourselves to our listeners and viewers. Dr. Bakoulis, let's start with you.
Hi, Dr. Huston. Thanks for having me. Hi, Dr. Lee. I'm Anastasia Bakoulis. I'm a breast surgeon here at Stony Brook. I've been here for close to 8 years now, and I specialize in benign and malignant diseases of the breast.
Dr. Lee?
Hi, thank you for having me. My name is Dr. Cindy Lee. I'm the Chief of Breast Imaging here at Stony Brook. I am the person who's responsible for reading your yearly mammogram, take care of you when you have abnormal finding, and also perform the biopsy if you do need it. So thank you for having me.
Thank you both. For many years, I've had the privilege of treating women in our community with breast cancer. These are fellow moms, colleagues, and friends, as well as their mothers, daughters, and sisters. Many of these women were fortunate to have had access to care. For most, screening mammogram afforded early detection. This was not the case for all. Breast cancer affects 1 in 8 of us. I am honored to have become a part of their journey and driven to improve the access to and quality of breast care in our community. The purpose of this podcast is to educate and empower. Let's start with Dr. Bakoulis. Tell us about the importance of regular breast exams, self-exams, as well as clinical exams by your physician.
Sure. Self-awareness, or the awareness of one's own breast tissue, the skin, the nature of one's nipples, really important in knowing or recognizing any differences that may come up in the future. That's what we mean by self-breast exams. The best time to perform self-breast exams are in the time right after one gets their period, so after you start to bleed. This is usually because breast tissue is less tender at that point in time, and also least dynamic. So the tissue texture changes that one could potentially appreciate in the days prior to the period can be very different. You need not perform a self-breast exam more than once a month. Some people feel more comfortable with twice a month, but really once a month is enough. So there's no right way to do a self-breast exam, but being consistent about how you do it is the best way. You can do it upright. You can do it with your arm over your head. You can do it in the shower as the skin is lathered up with soap. Sometimes it's easier that way. You can do it laying in bed.
Dr. Bakoulis, regarding risk factors and family history, who should be the most vigilant?
It's a great question, Dr. Huston. Folks who have a significant family history of cancer, and, we always ask about breast and ovarian, but different types of cancer matter too. So individuals who have a significant family history, whether it be in their parent, first cousins, aunts and uncles, those are the folks who should be a little more kind of wary of their history and their risk factors. Individuals who've had a series of biopsies in the past, that tends to increase a person's at least calculated risk of breast cancer. And then there are other factors like prior history of chest radiation as a young person. These are prominent risk factors to take into consideration.
I totally agree with Dr. Bakoulis. So breast cancer risk is additive, right? Mm-hmm. So we're adding all of your risk factor from the family history, your personal history, and also your prior treatment history. So everything get added together to calculate your personal lifetime risk of breast cancer.
That's right, Dr. Lee. We, on a daily basis in our practice, we use these nifty calculators when we meet folks who do have some notable risk factors. The most commonly used calculator is the Tyrer-Cuzick calculator, and this is readily found online. You can easily just pull it up on a Google search. But this is a very useful tool to help identify people who are at higher risk for the development of breast cancer, and there are things that we can do to them if that calculation is high.
So knowing that our greatest risk is being female, and then followed by all the risk factors that both of you just discussed, at what age would you like to see a woman come to you for her first screening mammogram?
So per the recommendation, American College of Radiology and the American Cancer Society, we recommend annual screening mammograms starting at 40. But if you have higher risk factor, for example, family history, personal history of breast cancer, or even genetic mutation, you have to start earlier. So your screening mammogram would then start yearly at 30, in addition to having supplemental imaging exams such as ultrasound and breast MRI.
Well, let's start with mammograms. Something that a lot of women want to know is the difference between a 2D and a 3D mammogram. We see this advertised.
So there's a huge difference in terms of technology and how much better the 3D machine is. So think of it this way. 2D only give you one picture, two-dimensional, and that's it. Whereas 3D give you multiple pictures, like a video through your breast, from the top to the bottom, from the side to the right to the left, and side to side. So it really gives you so much more accurate information and allow us to find earlier cancer at smaller size and earlier stage. So it really make a difference to make sure you're getting your 3D mammogram this year.
So tell our viewers what to expect when they make their appointment for a 3D mammogram and then they come into your office.
Okay. Number one, the patient usually are worried about pain and discomfort. It is not comfortable. So if the mammogram is done right, you should see a little bit of bruising. I typically do when I'm done with my yearly mammogram, and that's okay. Because of that 2 minutes of discomfort, you're saving yourself years and years of early diagnosis. You have better quality of life. So it's definitely worth it. It's just like a pap smear. No one wants it. No one loves it. But this is not invasive. When you come for your appointment, what we do is you'll be changed into a gown, and we will position you correctly on the mammogram machine. And then you'll have some pressure applied to your breast while we take a picture. And that's it.
Some other fears that women have shared are concerns for radiation exposure. And some women say, well, if I have a mammogram, is that going to give me breast cancer?
Love this question. That's my favorite question. So very commonly asked by patients. So the radiation equivalent of a mammogram is like a chest x-ray, right? And it's also equivalent of someone who take a flight from New York to California, and that background cosmic radiation you're getting is the equivalent of a mammogram. And there are people who does that professionally, ongoing throughout their life, and they do not have increased cancer risk. So my point is, it does not increase your cancer risk. It is a known minimal radiation, and it's definitely going to improve the outcome.
Dr. Lee, tell me about false positives. How often does that happen, and what does it entail?
So false positives happens when we bring you back for additional imaging, but did not find cancer. So that happens from time to time because maybe you don't have prior mammogram. This is the very first time we're meeting you. And sometimes it happens because you have dense breasts. Sometimes it happens because you made a new cyst or truly have suspicious finding in the breast. It's definitely happens. I had a false positive once, but I am happy to be there to get the additional imaging for that peace of mind. So I could be sure that all of my imaging on that second visit, I can get to talk to the radiologist and they can assure me that everything is good.
Now, you mentioned more false positives when you're having your first mammogram at a new facility. So is it better if women find a facility that they're comfortable with and come back to the same facility and the same radiologist year after year? Does that help you do their read?
So what helps the most is the access to prior mammogram. Let's say you went somewhere else for your first time and then you decide to come to Stony Brook to have your mammogram second. I strongly advise you to get that outside picture and then bring it to us. That way, you could be interpreted the same way as somebody who has been done here to minimize your false positive.
Dr. Bakoulis, let's talk about breast density.
Yeah.
What does that mean from an anatomic perspective?
Sure. Breast density is a very normal physiologic thing. The density is not something that you feel. Density is something that you can see mostly on a mammogram. Breast density is a reflection of how much functional breast gland there is in the actual breast. So a breast is made up basically of a couple of layers. You have the skin on the outside, a layer of fat that is very normal right underneath that. Then you have glandular tissue, which is a combination of ductal tissue and the milk-producing factory of the breast. And then you have stroma, so that you have the scaffolding part of the breast. Breast density is a reflection of that functional part of the breast tissue. As we get older and as our body sees less and less estrogen as a result of menopause, that breast tissue does eventually go away. And as a result, our breast tissue becomes less and less dense, which makes a mammogram even better. So density is not something that you feel necessarily, and it's a very normal thing in a person who is getting a very regular period. It's even normal in people who haven't had a period in a couple of years. But it's the actual functional breast tissue.
And Dr. Lee, how do dense breasts affect the imaging modality that you choose and how you read those?
So I wanted to also put this in context of how many people have dense breasts in the U.S. So as radiologists, we categorize your breast tissue into 4 different kinds of density. We call it A, B, C, and D. If you have C, category for heterogeneously dense breasts, and also D, extremely dense breasts, then we consider you having dense breasts. So in the U.S. population, typically about 40% of women will have category C, about 10% will have category D. So altogether, it means half of the U.S. women will have dense breasts. So this affects a lot of the women, a lot of the population in the U.S., and also throughout the world. So it's a really important topic. So in terms of what can you do about dense tissue, number one, this is normal. Just like Dr. Bakoulis said, it's physiologic. This is part of you. There's nothing wrong with you to have dense breasts. And number two, how do you take care of yourself if you do have dense breasts? What we typically recommend is to do supplemental screening. So to begin with that is ultrasound. Breast ultrasound is really great at imaging the dense tissue. Mammograms sensitivity decreases. As breast tissue gets denser, the ability of me to see your cancer decreases on mammogram. So typically, the first step we will recommend, an additional test, is breast ultrasound. And if you do have other risk factors, so that your lifetime risk is over 20%, then breast MRI will be indicated as well.
So as a plastic surgeon, I often get asked about implants and if your mammographic screening is different when you do have implants. So can you talk a little bit about how you image the breast and the implant in a woman who either has implants for cosmetic augmentation or in a woman who has implants for reconstruction after mastectomy?
Absolutely. Great question. So implants require special care. We do specialized views to displace, we call them implant displacement view, to push the implant out of the way of the mammogram machine. And they are a little bit tricky, so you do get more pictures taken so that we can see the breast tissue that isn't a part of the implant.
As someone who screens implants for many years after placing them in, I know our guidelines changed in coordination with the American College of Radiology about 5-6 years ago, such that when implants are placed, be it for cosmetic augmentation or after, we reconstruct following mastectomy, that we send our patients to you for an ultrasound at 5 years. And if you're happy with the way the ultrasound looks and you tell us the implant is intact, we stop there and then we send them back to you in 2 to 3 years for another ultrasound. But if anything abnormal is found on that ultrasound, then we ask that you do an MRI of the implant.
So especially for silicone breast implant, which majority of the breast implants are made of, they are difficult to see on the ultrasound. The sound wave actually does not penetrate through the capsule of your silicone breast implant. So what's the best exam, the best imaging test for checking your silicone breast implant is the breast MRI.
So let's talk about MRI for a minute, since we're on that topic. And I know that Dr. Bakoulis likes to screen her high-risk patients with MRIs as well. So I want to hear from both of you when you order and when you would recommend that a woman with her native breast, and not implants anymore, have a screening MRI.
Sure. So this is where genetic testing results are taken into consideration, Tyrer-Cuzick or other lifetime risk calculators, and their results come into play. Outside of a known genetic mutation that's related to a breast cancer, if a patient is identified to have a greater than 20% lifetime risk of breast cancer, this is where breast MRIs come into play big time for us. So in addition to conventional mammograms, plus or minus ultrasounds, depending on breast density, we alternate with breast MRIs. And we plan for this every 6 months. So if a person usually gets her mammogram and ultrasound in January, we would plan for a breast MRI for screening purposes in July. And so this way, every 6 months, something different is looking at the breast tissue. And it's a really wonderful way, a very complete way, in my opinion, to analyze breast tissue.
And I want to add the breast MRI is actually one of the most sensitive tools we have in finding breast cancer. It is good at finding anything that could be cancerous, even things that are not visible on mammogram or ultrasound. So
Agreed.
Absolutely.
Yep.
Moving forward to treatment after breast cancer. When a woman has breast conservation therapy, lumpectomy radiation spares her breast, how often do you want that breast image? And now she's at a slightly higher risk in the contralateral breast. How often do you want the other breast imaged as well?
Dr. Huston, that's a really good question. I do look to my radiologists for a lot of guidance. I think most breast surgeons will image the affected breast after a lumpectomy and radiation in about 6 months after diagnosis. And then subsequently, you resume your annual bilateral or both side screening. MRIs are a little more controversial. I definitely include MRIs as part of my screening if we find additional findings on the primary breast MRI at time of diagnosis. I think that would be very, very important, right? Obviously, an individual with a genetic mutation who pursued breast conservation therapy, that's an MRI is very important for those individuals. But I think, an MRI annually after breast cancer diagnosis is not an absolute must, but certainly a conversation that, a doctor and patient should have on a regular basis.
And I think it really matters when the patient was diagnosed with breast cancer. And also, is there any other risk factors, such as their first degree family relative with breast cancer? How old were they when they were diagnosed? So all of that come together and get added together to calculate what you mentioned before is the 20% cutoff.
Right.
So if you're clearly above the 20% risk for lifetime risk of breast cancer, then absolutely breast MRI is for you. But if you're not above the 20% threshold, we don't recommend it because it comes with rates of false positives. We don't want to do any unnecessary imaging or biopsy if we could avoid it. So MRI is not for everyone.
I can't agree with you more, Dr. Lee. Yep.
Okay, I'm going to complicate the screening question a little bit more. So we talked about how you'd follow up a patient who has implants or implants even after mastectomy. What about a woman who has a latissimus flap, a tram flap, a deep flap? after mastectomy, so has her own tissue in her newly reconstructed breast, but it's not breast tissue. What type of screening would you recommend for that patient?
So for a patient who had a total mastectomy with no longer any residual breast tissue, then we do not recommend mammogram. Mammogram is really designed for imaging breast tissue, not flaps, not reconstruction breast tissue. So in those cases, if these patients are asymptomatic, ultrasound could be of use, and also breast MRI if they still have the other breasts.
Would you recommend breast MRI on the breast that's had mastectomy and reconstruction, or just on the native breast?
Good question. Breast MRI is done bilaterally, meaning whenever you go for MRI, we look at both. Doesn't matter what.
And Dr. Bakoulis, after we've reconstructed someone, how frequent should that woman be undergoing clinical breast exams by her breast surgeon or plastic surgeon or her gynecologist?
Sure. In general, we do recommend an annual exam at least for the first 5 years especially. And again, promote breast awareness, even though there isn't really a native breast there anymore, but just a learning of what your new reconstructed tissues feel like now.
And then if you were to have any new symptoms or a new palpable lump, definitely come back. We could do an ultrasound. It does not have radiation. You do not need contrast, but it's a great way to evaluate any concern you have.
Absolutely. Absolutely. And if ultrasound, we can even do MRIs like you mentioned earlier. There's always a way to visualize things and investigate things even after a mastectomy.
This has been a tremendous amount of information. If you had to leave our viewers with one key message or request, what would you say?
I think know thyself probably is the number one recommendation I'd make. I think it's important. Women are moms, they're caretakers, they're busy people, and they're always taking care of someone else other than themselves. So recognizing what is your normal is not the most natural thing sometimes. So know what your normal feels like, know what your normal looks like. And of course, if there's any questions or you have concerns, only you know you best. So reach out to your gynecologist, reach out to your doctor, reach out to your breast surgeon. Right. And if you've noticed any changes, it's important to come forward with these concerns immediately.
Excellent. Thank you.
I like that message. So my take-home message for you all tuning in today is that make sure you did your screening this year. If not, we have a lot of different locations that's convenient throughout different communities, Riverhead, Comac, Stony Brook, the hospital, Southampton, West Hampton. We have numerous number of locations designed to give you most access and best equipment possible to help you get your screening done. So check.
And my tip relates back to plastic surgery again, and it's take care of your implants. Implants need attention. They don't always need to be changed. You don't always need another operation right away, but it's important to get your screenings. And if something feels abnormal to you, like you mentioned, on your native breast, on your augmented breast, on your reconstructed breast, call one of us. And we're here to figure it out and to help you. So that's all the time we have for today. Thank you so much to our panelists, and thank you to all of you, our listeners and viewers. Remember, screening is your best first step. For more resources, including information on screenings, you can call the number on your screen. And if you found this information interesting or helpful, please like and subscribe for more content like this.
Stony Brook Medicine is Long Island's premier academic medical center. We transform lives through scientific discovery, education, and care, and we bring together innovative research, advanced education, and extraordinary healthcare expertise to set the standard for how healthy communities thrive. For more information, visit stonybrookmedicine.edu or follow us on social media. Stony Brook Medicine on Instagram, Threads, Facebook, YouTube, and LinkedIn, and Stony Brook Med on X.